Good
Go on,
morning.
Peter.
My name is Peter Young. I'm an anaesthetic and critical care consultant from the Queen Elizabeth Hospital in King's Lynn. I'm also an elected council member of the Association of Anaesthetists, and I chair their safety committee. It's Saturday the 14th of March 2020, and I'll be chairing this morning. Thank you for attending this COVID-19 webinar. It's provided free, live and online, courtesy of the Association of Anaesthetists. We've drawn together experts to offer advice as we prepare for the wave of patients that we're expecting in the next days, weeks and months. To give some context, the WHO has now declared Europe as the epicenter of the pandemic, and the UK government describes this as the worst public health crisis of our generation. So firstly, we have speakers from China and Italy, and we thank them for the precious time they're giving to us to provide valuable first-hand experience of managing COVID-19 and in the context of an overloaded healthcare system. We've got Professor Tim Cook talking on epidemiology, the impacts on healthcare workers and AIRWAY guidance, Dr. Ferguson about ethics and leadership, Dr. Matt Davis will be talking about organisation, planning and logistics, and Rob Self will discuss morale and welfare during this unprecedented period. After this will be addressed by the President of the Intensive Care Society, Ganesh Sunthanarangam. We have a very full programme, but you can submit questions online and we'll try to address some of these when time permits. So firstly, we have Professor Tim Cook, who has rapidly become the UK's leading authority in intensive care for COVID-19. So Tim, please go ahead.
Now, I'm just going to swap my screens. I'm not sure how this happened last time. You got my...
Hi, Tim, just do the display settings.
Display settings.
In the middle at the top, you've got three options at the top of your screen.
Yes. Sorry, guys. Oh, yeah, okay, sorry, yeah, up there. Display settings, yeah.
And then, the one that says toggle. That's it.
Sorry, we're not at the start, my apologies. Should be smarter than this. Right. Okay, so hello everybody. I don't know who's online. I'm told that there are about 1,000 of you. There's a lot to get through. The first thing is to say is I am in no way an expert on this. I'm someone who's paid attention. I'm an anaesthetist and intensivist in a DGH in Bath. I don't work in a large centre. I have no infectious diseases expertise. I've been aware of this for I guess now 6-8 weeks, same as most people, and I've tried to pay attention. I'm going to go through some of what I know, and as Pete, I won't repeat what Pete said I'm going to talk about. They're scary times. Perhaps the most important thing for anaesthetists and intensivists to get hold of today is that the four bodies that regulate and support us, that is the Intensive Care Society, FICM, the Association of Anaesthetists and RCOA have joined together to have a single hub to provide information for intensivists and anaesthetists who increasingly will become one body over the next couple of months. These are the numbers of COVID, and I'm just going to put that slide up there and then come back to that. Our zero is about 3, the attack rate may be 30%, 2% of patients get critically ill, and the mortality, you'll see a lot of different numbers there, which we'll come back to. So with Karim El-Baghdadi, I wrote a blog last week, which you can also look at to look at the numbers in a bit more detail. So I gave a talk to the AIRWAY leads of the UK now 9 days ago. On the top left, you can see the cases when I gave that 9 days ago, just under 100,000 with a roughly 3.4% mortality rate. And now just 10 days on, we're approaching a 70% increase in that and approaching 150,000. These are figures from Worldometer, which is an excellent resource. These are total cases and total deaths. They look pretty horrific. They look even more horrific if you realise that you see the acceleration on the graph on the right. So the doubling time is something like 5 to 7 days in outside China. There are various different mortality rates in different countries because of different testing policies, which makes it difficult to compare different countries. Again, this is now somewhat out of date. This was the rate of spread as shown on the BBC website over a 5-day period. And you'll see that Japan moved from 500 to 700 cases. And in that same time, Singapore from 75 to 204. But at that time, the UK and the US were well down the rankings in terms of cases. Things have moved on apace. We now know that the two major epicenters, well, perhaps the three centers, but China, and then following that, both Iran and Italy at similar times. And since then, spread has occurred right across the globe in a way that didn't happen in China, because China had a relatively localized epidemic. More than 700 million people had travel restrictions of some sort imposed quite quickly, and control has been achieved in China. Again, from Worldometer, you can look at this on a daily basis to see how things are changing, and the numbers in China at the top at about 80,000 have changed very little in the last 10 days, whereas those, for instance, if you look at USA, 2/3 of the way down the pack here at 137, we now move here, and Italy is at over 2,000 cases with more than 100, and probably a lot missed because of their testing policy and their testing problems. This is what the epidemic looks like. That's a very short period of time that epidemic passes through. From the left line here is where we are. We're probably at about week 6. This is week 20. So this all happens in a period of 3 months. So we have yet to reach the point of acceleration in the UK. And when that hits us, that will be fairly horrific. This is the point of the NHS's ability to cope with the surge. It will be overwhelmed. So we'll see that China, outside China, cases have increased. I'm going to use a couple of graphs here just to show the scale, the rate of change in the UK. So this was, what are we now, 12 days ago. These were sporadic cases starting to happen in the UK. A suggestion that things were increasing towards the end, towards the beginning of March. And then 2 days later, a dramatic increase here on the right-hand side. But if you make the scales the same, it looks even more impressive. We can do that the same now 10 days on. And look, that's the 2nd of March down there, and here we are on the 24th of March. Or even the 14th of March. I'm 10 days ahead of myself. In China, essentially cases are petering out. Their crisis for the time being has happened. Whether when they lift restrictions of movement and activity, reopen schools and reopen businesses, things will recur is unknown, and there's much debate on that, but that may happen. It's difficult to know what the mortality is. These are all figures taken from reliable sources, and they give remarkably different mortalities. The problem is that they don't necessarily take account of the ascertainment, that is the number of cases that have been detected, or the proportion of cases that have been detected. They have different denominators, and they look at different groups. So we'll look at that in a little bit more. So if we have in the middle the cases we know about, then there are a proportion of those will be severe, and a proportion of those will die. There are undoubtedly a very large number of infections which are not detected as cases. That may be an 8-fold greater number of infections than there are cases. The ratio of real infections to cases is the ascertainment rate, or the detection rate. And the ratio, as we can see here, of cases to mortality is the case fatality, which is generally probably the most important event, whereas the infection for mortality rate is this here. But many of these will just simply not be seen. We, of course, in hospitals are interested most predominantly in the severe cases and deaths. This is a disease which strikes very much unlike swine flu at the elderly. So with swine flu, the elderly had some lingering immunity, and their mortality was reduced compared to those in the Middle Ages and children. This is completely the reverse. In children, it almost doesn't exist as a severe disease, whereas in the elderly, it has a mortality rate of horrific proportions. So let's go through those numbers again. The R0 is the number of patients that an index case will infect. So a single infected patient is likely, on average, in an uncontrolled situation, to infect roughly 2.5 to 3 individuals. If we compare that to other dangerous illnesses, pandemic flu had a rate of about 1.3. Ebola has a rate of 2. SARS and MERS have R0s which are below this one. To compare those, flu with an R0 of 1.3, if there are 10 cycles of infection, that will lead to about 14 people being infected after those 10 cycles. Because of its geometric pattern, an R0 of 3 means that that same 10 cycles leads to 59,000 people being infected. And that's why we have the problem. The vast majority of these cases are asymptomatic or mild, and we probably don't know roughly tenfold of them. That's the ascertainment rate. So we probably only know about 1 in 8 or 1 in 10. Because of this lack of immunity, the expectation is that 30 to 60% of the whole population will be infected over the next year. Some estimates as high as 80%. There have been talks in the last 2 days about herd immunity, and I'm not sure how much of an attack rate is required to create herd immunity, but I don't understand that at present. Of the patients who are detected, so the known patients, roughly 1 in 8 require hospitalization, and these patients are very sick, with 1 in 6 of those hospitalized patients, maybe higher, becoming critically ill. And of the critically ill patients, approximately half of them die. So the World Health Organization posts a mortality rate of 3.4%, and that is roughly, so that is between 2 and 4% in different countries of those that are detected. But the mortality amongst actually infected cases is probably closer to 0.3 to 1%. The incubation period is 7 to 14 days. And although we think people are infected for 14 days, that can be as long as 30 days of great concern. So let's put some numbers into that. If we had 100 cases, then roughly 800 would be in the community, of which we only know 100. 10 to 15 would present to hospital as severe cases, and depending on healthcare resources and preparedness, roughly 1 to 3 would die. This is again the peak of the epidemic. The government's phased response. The containment phase at the top aims to actually reduce the size of that peak, to actually of the whole graph, to actually control and reduce the actual number of cases, which perhaps they've been successful with in China with that massive isolation. The delay phase, which we've now entered, acknowledges that we cannot decrease the number of cases, and it simply aims to spread the same number of cases without reducing them over a larger period of time. Although I know there are some papers on modelling which suggest it may also actually decrease mortality, and that's because we stay under that blue line and we can cope with the number of cases. So this is the best paper that I've seen on the topic in terms of epidemiology. It's a remarkable paper published towards the end of February, looking at 72,000 cases from China, with data collection going up to about 8 days before they actually published, and we'll run through it quickly. But just to emphasize, without going through this here, when the Chinese classify their diseases as mild, severe, or critical, those are identical classifications to those that we would use in the UK. So here we see in the first 3 yellow rows the massively increased mortality associated with increasing age. So you'll see here there were only 400 out of this is 45,000 cases, only 400 children, only 1,000 below 20, of whom only 1 died, whereas we have almost 1,000 deaths in this group here. A slight preponderance of increased mortality in males, health workers representing 3.8% of confirmed infections and 0.3% of deaths, which is overall roughly similar to the overall mortality, which I'll come back to. Risk factors: hypertension, diabetes, cardiovascular disease, and to a lesser extent, chronic respiratory disease and cancer. And by the way, if I start coughing, that's not COVID, that's my asthma. So cardiovascular disease is the most prominent one here. Cardiovascular disease is undefined, but hypertension by itself is also a risk factor. And then another really interesting, well, two interesting factors. First, critical illness, roughly 50% of patients dying. So that's patients with organ failure or needing ventilation. And then over the period of the epidemic, over the period of reporting, a dramatic decrease in the case fatality rate. Now, in the last cases, there'll be some lead time bias, meaning that there'll be patients who are still sick who haven't yet died, some of whom will die, so that will increase. But here, there does seem to be a genuine decrease in the number of patients affected. So those are the figures presented in a slightly different way. And of course, your mortality, your overall mortality, entirely depends on your denominator and then your ascertainment rate. Right, I'm going to move forward quite quickly. It spreads incredibly quickly. This distance is about 4,000 miles in 40 days. And this is a superb paper. This is a JAMA interpretation of that Wuhan, the CDC paper, showing that increase in symptoms and increase in hospital, and then diagnosis. So symptoms and diagnosis, about a sort of a week's spread. And this is the activity that happened. I haven't got time to go through it, but the response of the regulators, the WHO, etc. So we have here December the 31st, WHO was first informed of this problem by the Chinese authorities. That's why it's Wuhan 2019 or COVID-19, because it happened on New Year's Eve. Important to note that in terms of the disease, illness, acute respiratory failure and intensive care admission often occurs about 10 days into the illness. So people don't present, this first I've got my symptoms and now I need ventilating. It's usually 10 days. And there may be a myocarditis and a fatal death, which occurs even later along this. Briefly on healthcare workers, I'm afraid this is a picture of the ophthalmologist who made early statements about the virus and was unfortunately one of the early fatalities in China, and certainly there have been fatalities. And I don't know if the numbers are reassuring or horrific. And I think being a healthcare worker is an increased risk factor for getting this illness. In early reports, 40% of infections were hospital acquired, and 2/3 of those were healthcare workers, with the other 15% being patients. But that decreased over time. So here we have 3.8% of infections and 0.3% of deaths. The reason it might be a concern is because the ascertainment rate in healthcare workers is probably higher than the population. So probably they're a captured a group of people. So they're probably not captured is the wrong term. So they're a clearly identified group of people, clearly defined. And if they become ill, it's probably detected quite early. So the concern is that ascertainment rate is high, and therefore that mortality rate is disproportionately high compared to other groups in that paper. Here we'll see that some of the individuals are asymptomatic, which we'll come back to, and again that 0.3 mortality rate. Similar stories in Italy, I'm afraid. So this just shows the speed of response. This is the speed of response, which is a number of days for WHO to respond, to be able to type the virus and to move forward. This was months with SARS when information was suppressed, and the global response to pandemics has improved dramatically over the last decade. So yeah, so one of the concerns is that of those 3.8% of patients who, healthcare workers who were infected in that large paper, 15% were severe or critical, which are the same numbers as for the larger population, but in the larger population, they're probably low ascertainment, whereas this is high ascertainment. Similar story in Italy. This is early data from Italy. 8% of cases are healthcare workers, according to this, and certainly there are healthcare worker deaths. How do we diagnose it? I'm going to skip through this very quickly. Most of the infection is in the respiratory area, so that's in the throat, nose, and deep and in the trachea, and that's where you should be sampling from. This is the bad news. There's viral shedding early in the disease, before people are symptomatic, including possibly during incubation. There is sometimes persistent shedding and the sickest, but the sickest do shed more. So we will be exposed to more virus. The next slides I'm going to skip through so that they remain on the website for people to look at, but they're not. I'm not going to go through the detail of them. Just to mention here that here we have significantly high rates in BALs, followed by sputum, followed by nasal swabs, with nasal swabs having the highest rate of virus and therefore the lowest cycle threshold. It hangs around for quite a long time, so you can see here it's unwashed, so you can decontaminate quite easily with normal decontamination processes, but if you don't do that, it hangs around for a very long time and puts us all at risk. So these ones I'm skipping through, and then I will talk briefly about PPE. This is from our tea trolley training, and these are Fiona Kelly's cupcakes, Corona cakes. PPE testing is absolutely necessary. It will save lives. So that reduction in case fatality rate in China may well be due to an increase in use of PPE. And proper PPE reduces viral exposure roughly 100-fold. We've mentioned that. But there is variability in what people do. This is our PPE initially in Bath. We're actually having enhanced PPE for intubation. This is what's recommended by PHE, but in other places, people are doing considerably more. There is uncertainty as to what we should do. In the 4th of March, FICM released some advice, and it was extensive. It included triple gowning, sorry, not triple gowning, triple gloving and double gowning, whereas PHE recommends something different. I'm not going to make any comments about what is right or wrong, but I will make one comment, which is that whatever you do, you have to make sure that what you do is sustainable. PPE is essential for airway management. It's essential for resuscitation. Resuscitation is going to be important in these patients. You must put your PPE on before you start resuscitating. So I'm going to skip through that last section briefly on airways. I've coined the term that it should be safe, accurate, and speedy. That's SAS, airway management. Safe for staff and patients, accurate, avoiding unfamiliar, unreliable, or repeated techniques, and speedy. So I'm just going to highlight the next few slides. We've come up with some guidance which will appear on the central hub in the next day or two. Guidelines normally take a year or two to develop. We've done this in a week. There is a one-page summary of what we think we should do for airway management. There is an important, probably the most important bit, is a new checklist based on the one originally developed in the Southwest, then used by DAS, and that emphasizes the personal protection and preparation outside the room. Before all this preparation is outside the room before going in, and then actually the actions, and then inside the room, and then moving out. It's all about protecting yourself to maintain the workforce, keep yourself and your family safe. We've developed a new algorithm which we slimmed down from the ICS, from the DAS critically ill guideline. PPE, a senior operator. There will be no sidebar help, no high flow nasal oxygen or NIV. This is about aerosol generation, but also about preservation of oxygen supplies. We can run out of oxygen. Don't use bag mask ventilation if you need to, unless you need to, it's aerosol generating. But if you do, two people, two-handed, and a V grip. Ketamine and rock, full muscle relaxation to ensure no coughing. Use your video laryngoscope first, and vortex if you're in difficulty. So that's the V grip. You get a better grip if you do that than if you do the C grip like that. We suggest you use a dump kit with a minimal amount of information of stuff going into the room. This is the proposed setup, a minimum of 3 people, the intubator, the only intubator, the assistant, someone doing drugs and monitor, and a runner outside the room. So there, and then a slimmed down algorithm for front of neck airway, and that's it. So lastly, the most important thing about the whole, I think, of this talk is this hub where information will be available, and the cooperation between these 4 organizations as we join as sort of one body to work together with people from each of the specialties, and of course from specialties outside anaesthesia and intensive care over the next months. Good luck is all I can say. It's going to be pretty tough. Good luck to everybody. Thank you.
That's great. Thanks, Tim. Are you still online?
I am, yeah.
Take some questions. There's a few questions coming in. Some of them may be more appropriate for a virologist, but I'll see if you can give your take on it. The first one is, if I get COVID-19, will I be immune afterwards?
I think the answer is that's uncertain. There's a big assumption that people will be immune. That is untested territory, as far as I know. There are case reports. I think there's a case report from Japan of an individual getting reinfected. But I think for the time being, we work on the assumption that there will be some immunity afterwards.
That's great. The second question here, there's been a few people talking about the risk of elderly and or retired doctors coming back. And I know that we've had quite a number of inquiries relating to members of staff who have comorbidities. Is there a sort of position on that at the moment?
Yeah, in the guidance, which I think may come out today, there's a specific statement on that and those high-risk groups, recommending that those individuals, whether they be intubating or part of the intubation team, should think very carefully, and their department should think very carefully about whether they're involved. So the sort of inflection point in terms of increase in risk certainly increases after 60, and I'm not sure where between 60 and 65 it increases. The other thing is that all those risk factors were based on univariate analysis. What would be really nice would be to see that, because of course the older folk are going to have more hypertension, diabetes, cardiovascular disease, and separating whether it's age or the comorbidities, which are most important, would be really nice. So it'd be great if somebody could get hold of that data and sort of shake it and actually work out what are the true risk factors rather than that univariate analysis.
That's great. There's some questions about running out of PPE, and I think you alluded to that in your talk, that although we need to follow all the guidance, we've got to be cognizant of the fact that we don't want to be wasting a potentially precious resource.
PPE is part of a system of protection of staff. I, in my reading, have become increasingly convinced, I've not spoken to virologists about this, but increasingly convinced that fomites are just as important as aerosols for infecting people. So we need to cover ourselves, but we don't need to go over the top. The evidence from the SARS epidemic in Canada was that overcomplicated and confused PPE led to increased rates of healthcare worker infection. So we do need to keep it simple, because doffing is complicated, and removing PPE is probably when contamination can occur. So cleaning is really important. Disposal of waste is important. Keeping your PPE simple, and also sustainability of that PPE. So maintaining stocks. So it's wrong to overuse PPE. You know, there's a question as to whether we should just be using face masks once the patient's intubated, rather than FFP3 masks, and that's something which is undecided. But I think probably we should be. Otherwise, we will run out of stuff.
That's fantastic. Thanks very much indeed, Tim, and thank you for the time that you've given this morning. Okay, we'll move on. We've got Dr. Song with us. He's the Director of Intensive Care at Shenzhen University General Hospital. He's going to talk about the management of the critically ill patients that he's seen with COVID-19 in China. Dr. Song.
Can you hear me?
Yes, we can hear you.
Okay, hello everyone. I'm Zhi Song from Shenzhen University General Hospital. So, as you know, there are nearly 500 confirmed cases in Shenzhen, 3 dead. So today I have a death case to share. This is a 66 years old man. He had fever, cough for 8 days. And admitted on January 11th. From December 29 to January 4th, the man had been to Wuhan. There were a total of 6 people accompanying him and one with the same symptoms. In Wuhan, 3 of his relatives and friends had fever. His wife also had fever and cough symptoms and lived in the same ward. His daughter, son-in-law, and grandson were quarantined in Hong Kong University Hospital. There are ground glass shadow and spot shadow in Lan City. On January 10th, chest CT examination showed multiple exudative lesions in both lungs. On January 14th, COVID-19 nucleic acid was positive. The lab examination in the University of Hong Kong Shenzhen Hospital told us white blood cell count was 4,200. Lymphocyte percentage was 17.4%. Renal function was normal. Chest CT indicates multiple exudative lesions in both lungs. Infection considered. He has a history of hypertension for more than 8 years. On January 11th, we gave the nasal catheter, and from January 14th to 19th, we gave the non-invasive ventilator ventilation. These are image data on January 13th. We can see ground glass shadow. On January 23rd, CT findings of double lungs were more severe than before. On January 30th, the patient had high fever and shock. Oxygenation index was 68, so we used VV echo. January 7th, the patient had pulmonary hemorrhage. Swab and valve. The viral CT value on throat swab was negative, so we found that there was high virus detection rate in patients' valve. This is antiviral and anti-infective treatment. We adjusted the treatment plan in time according to the results of the bacterial culture and the drug sensitivity experiment. Diagnosis of death on COVID-19 pneumonia, critical, severe ARDS, MODS, pulmonary hemorrhage, bacterial pneumonia, and so on. After the patient died, the lung tissue was examined by pathology. It was found that mucosa of the main airway and the small airway was damaged and bleeding. No correlation with Aspergillus infection was found. And we have some limited experiences and lessons to share with you. About the route of transmission, there must be human-to-human communication. We found that a lot of patients had family clustering. Our data suggests that there are infectious viruses in the blood and feces of patients, but no virus is detected in the CSF. Most of our patients have epidemiological history and have been to Wuhan or other cities in Hubei province. The common symptoms are fever, cough, and fatigue. Some patients have gastrointestinal symptoms. The patients with severe and critical diseases are mostly old, accompanied by the basic diseases such as hypertension, COPD, and so on. More than 80% of the patients had abnormal chest CT, which showed bilateral infiltration. There are also some patients who did not find CT abnormalities when they first came for diagnosis, and then CT images gradually became worse. More than half of the patients' peripheral blood lymphocyte count disease decreased, and the recovery of lymphocyte count in critical patients was slow. But we have no evidence to prove that it is related to mortality. Decrease in oxygenation index and increase in D-dimer are common. Antiviral therapy, our patient was treated with Kenetra, Bedo, and Ribavirin. And we used interferon alpha. At present, there's no evidence to prove the validity. And no indication of antibiotic use in early stage. Evidence of infection after 7 to 10 days use as appropriate. For treatment, all severe and critical patients receive oxygen therapy. About 2/3 patients receive mechanical ventilation. Our respiratory support treatment sequence: high flow oxygen therapy, non-invasive ventilation, invasive ventilation, ECMO, in which invasive ventilation should be carried out as early as possible. The effect of ventilation in prone position is obvious, and it has become a routine treatment. Each time is more than 60 hours. 40% of patients receive short-term low-dose hormone treatment, and we give the immune support, and the traditional Chinese medicine seems to be effective in statistically analysis. Early internal nutrition was important, and the peri-internal nutrition alone is not recommended. And these are indications, modes, and meanings of ECMO treatments. There are a large amount of mucus in the bronch alveoli of patients, which was very important and may be one of the main reasons for the high mortality of the critical patients. We also found that in the late which may be related to the mucus. So these are the intensive care, including different levels of protection and the filter psychological evolution and counseling. Lastly, the common complications include secondary infection, DVT, side effects of drug, diarrhea, kidney injury, and bed sore. Thank you for listening.
Thank you very much, Dr. Song, and thank you for the time in your busy day. There's a few questions coming through. One of them relates to CT scans. It seems to be a theme that many of the papers coming from China talk about CT scanning for both diagnosis, and it seems to be very commonly done there. And I think that the moment the UK position is it may be less commonly done here. Are you doing the CT scans for diagnosis or for another means for progression of the disease? Dr. Song? I think we may have lost Dr. Song. Okay, we'll move on to our next speaker. That's Dr. Storti. He's the director of the emergency department of Lodi Hospital in North Italy, and he will be presenting his experience of COVID-19 in the setting of the outbreak of the pandemic in northern Italy. Thank you very much, Dr. Storti.
Okay, good morning, everybody, and thank you so much for inviting me. I will try to give you, let me say, the taste about what happened in Italy and what happened to me and my team, because we suddenly jumped in the middle of a pandemic and an epidemic, and now is a pandemic problem with COVID-19. And let me say that my talk has been done after 18 hours in a row in ICU, so please forgive me if the presentation is not outstanding like the previous one. But anyway, let's go ahead. This is more or less my background, and I have no conflict of interest, so we can go ahead. I will also present the experience and the great help that Professor Davide Manca gave to me in order to find a way to obtain some model about what gonna be the near future for Italy. And let me say that this is an outstanding occasion which I like to cite to share with you what gonna be in UK, because finally what we perceived is that the curve compared with Germany, France, and UK, I think will be very, very similar. So I think that sharing this experience just like we are doing is absolutely the right way to go. So I would like to thank Professor Manca for his help, because his calculation skills is well beyond mine. So finally, this is more or less what is the area where this Italian outbreak have been starting. And unfortunately, we were exactly in the middle. So we have been, let me say, the front line, and we have been the point man to solve this big and unexpected problem. So you see that Lombardy is, you know, the major one of the first or the second region in Italy, not only for population but also for economic deployment. So here is what we did, what Professor Manca did, is trying to have an idea about what is the correlation between ICU, the ICU patients. And you see in orange what is the prediction for the next few days. And as you can see here in Italy, we are we have not reached yet the peak of this epidemic. And let me say that this is for us very bad news, because I can promise you that our ICU facilities and our ICU standards has completely been destroyed, let me say, by this outbreak, because what we are doing now is that we are being forced to work in a very different way. This is a key point, is a key message I would like to leave you. You cannot deal with such a number of patients, with such a so narrow period of time, receiving a huge number of patients with ARDS, treating them in the same way. Otherwise, you are completely overwhelmed in hours, and this is exactly what happened in some hospital not so far from ours. As you see, also from the maths perspective, we are in ascending part of our curve, and this is something that we have to keep in mind. And you see that when the dynamic of this epidemic is is like that, you see that unfortunately next week for us will be, I think, even worse compared with the previous one, the two previous ones. And you see that in terms of ICU patient, this is a tremendous effort that should be done to deal with such a number of patients. And you see that this is not only Italy, but this is exactly my region, Lombardy, where we are, where I'm talking now. And you see that this is something which is absolutely challenging our healthcare system, because in all the region, and I will show you later some figures, the hospital has been forced to completely reshape their protocols, their words, and the ICU has been enlarged 2, 3, sometimes somewhere 4 times in terms of number of beds. And this is again an issue. And you see that this is a calculation that Professor Manca and I did in the last 3-4 days, and this is the time required to double the numbers of ICU beds, and this is very impressive to me. And this figure gave me exactly the idea about what we are facing now and what's gonna be the near future, because you see that finally, and I promise you that from the methodological perspective, this is a very reliable prediction. You see that we have 3 days, more or less 3 days in Italy, and something more because in Lombardy, in our region, because our healthcare system here is very nice, and let me say a little bit better compared with some other area in our country, I mean the south, for example. And you see that we have a very short time. If you are not being prepared to double your ICU beds in 4 days or 3 days, it's up where you are, this is gonna be a mess. And I will give you, this is a strong message I would like to leave you, and so be prepared, get ready for this, because if the curve will be more or less the same, this is something that for sure you will be forced to face. And here you see that you have the great chance to be 15 days behind us. So let me say that if this is, I don't know if 15 is perfect, but maybe 12 or 10, but you have time. You have time to get ready. You have time to reshape and deploy in a different manners your ICU beds and reshape also the emergency department protocols, just like we did. But unfortunately, we have been forced to do this without stopping to look after our patient. And that, believe me, has been a real mess. So you have time, use this time accordingly. And this is something that is not only medicine, is also some governmental issues, but you see that I mean this outbreak and this pandemia and COVID-19 is a really virulent virus. So I think that we cannot leave this virus go through our community without any social distancing or other methods in order to maintain very low the number of infections, because otherwise we'll be have in front of us a large number of patients reaching and referring to our emergency department at the same time, just like we have experimented in the first week. And believe me, this is something that is really hardly to imagine. And you see that this is not only an idea. If we look back to history, we found that you know, these kind of measures are working, and so this is not only for physicians. This is not only for doctors, but also politicians should look at these charts and curves. And here is something that is exactly what we did, and you see that we have completely reinvented our emergency department. I would like to acknowledge our emergency department in chief, Dr. Paglia. He did an amazing job, and you know, the opportunity we had to work together, I mean, emergency department and intensive care physician, is the real secret to have the chance to survive, because we cannot work as a separate at such an extent, because you know, a large part of this struggle is in the emergency department, and the intensive care physician should be there not only to take care of the patient, but also to address and to be sure that the balance between resources and number of patients is administered in the proper way. Why? Because finally what we had in front of us in my hospital was a real mass casualty. Mass casualty is defined by the disproportion between resources and the number of patients to be treated. And believe me, this is exactly what happened. And you see that we have reshaped our emergency departments, providing some ICU bed there, and providing a space which was not present before, where a patient could be treated by CPAP system, because we receive 150, 200 patients per day with ARDS. Believe me, it was something that you couldn't imagine. So you cannot intubate everybody. You cannot adopt a prone position for everybody. You cannot do bronchoscopy for every patient. So we have to deal with patient by one side, but also by time by the other one. We have a short period of time with very sick patient, but you cannot treat all the patient with our standard of care. Otherwise, you have been overwhelming in a few hours. So we were forced to treat this patient in the emergency department, just waiting to make enough beds, enough room in our ICU. And you see that this is something that astonishing me still today. My ICU was a 7-bed before this COVID-19 outbreak. Now we are taking care about 22 ICU beds. And as has been mentioned before, we are not doing this with our previous team, but because my team has more or less the 20% of COVID positive physician. So we are dealing with these 22 beds with a 20% reduction in our team. And this is another issue because this number, this crew problem is something which is limiting, consistently limiting your reaction capacity. So this is something that we have to take care. And you see also that you can imagine that it's not possible to deal with this load only with ICU beds. So we have completely rebuilt a step-down unit of 18 beds. And again, another issue is that just because we have not enough intensivists, we have also redesigned the crew, the clinical staff, and so in this step down unit, there's not only let me say an intensivist, but a pneumologist, infectivologist, and whoever is able to dealing with CPAP and not invasive max ventilation. And you have a large portion of a critical patient, but for one patient that has been intubated, more or less we had 5 to 7 patients who need non-invasive max ventilation, and more or less 20 or 30 patients that should be oxygenated. They need only oxygen delivery, and this is more or less the ratio that we found. Okay, I will try to give the taste about what happened. This is these are aisles of our emergency department, because all the other rooms has been completely filled by patient, and so this is the you know, the kind of mess that we have been forced to deal with. And you see that even if you reinvent the hospital, even if you reshape your hospital is forced to pay a huge price for this crisis, because you see that also what we can call the normal, the average activity of our hospital is completely destroyed. Let me say severely limited. I don't know exactly what is the English term for these figures, but you know, this is how now our hospital is working, is considered a COVID positive hospital, and so all the elective procedures of course should be guaranteed, but we have designed for achieve this goal different pathway inside the hospital, and believe me, this is not so easy when you have such a large number of COVID positive patients. This is in Italian, but the only figure important is 152, which is the number of not ICU's bed, so medical beds available, and you see that 146 beds are fully occupied. So we are filling up our beds and our resources. And you see that more or less now on about 400 beds, you know that half of more than half, more or less beds are dedicated to COVID-19 positive patients. And you see another important issue is that you see the red code of our emergency department patients. This is another critical point, because we receive more or less the average number of patients we received before this epidemic, but the green and the white codes completely disappear. So when we receive 150 patients at the same time in 12 hours, more or less, they are all red and yellow codes, so people with a severe respiratory distress. So the intensivist has in front of him a large number of patients completely with a high ICU dependency to be addressed in a hospital where there's a huge disproportion between ICU beds, resources, and X-ray, CT scan availability, and the number of patients themselves and the ICU beds. Again, we are in Italy. You are in UK, so we have all the gold standard. We have a huge standard of care. So CT scan for sure is the gold standard. But believe me that when you receive 30 patients per hour with an ARDS, a clear and ARDS, not mild but severe ARDS, there's no time to use a CT scan, and that's exactly what we did. Some hospital around us didn't do this choice, and they tried to go with the CT scan, and they collapsed in hours. You see, this is what a CT scan demonstrate. I will skip this because it's something that you know better than me. But this has been our approach, to use a lung ultrasound. Lung ultrasound is a point of care examination, and no time consuming, repeatable bedside with a huge clinical fallout. I mean, ultrasound is able to change the clinical decisions and is also a very, very effective monitoring tool. And exactly how we use ultrasound. And this is, if it works, okay. This is a clear pattern of ARDS depicted by lung ultrasound. You see that you have, sorry. Okay. You have some spare areas and some very sick and with a huge derangement in the pulmonary parenchyma. This is a very clear pattern of ARDS. And you see that finally, when you are skilled with lung ultrasound, you can find a huge correlation between lung ultrasound and lung CT. Okay, I think that this is my last slide. I hope that my English has been sufficient to spread this message, and I do apologize for my terrible accent. Thank you so much.
Thank you so much, Dr. Storti, and in particular with the length of time you're having to work and what you're expecting to come. We've got, as you might expect, a lot of questions, so I've just filtered a few out. So you were saying that there's been about a 4 times expansion of your ICU. In the UK, I think many people are thinking of moving into the operating theatre areas. The operating rooms. Is this something that you have done in your hospital as well, or did you just expand out elsewhere?
No, this is a very nice question, and you're right. We couldn't cope, of course, only enlarging our ICU, and so I have occupied a little operation room theater aside our ICU, which is on an average base dedicated to the ophthalmologist, and I did there five ICU beds. and I completely reshaped my 6 step-down unit beds I had before this outbreak with ICU beds. And I used the 18 beds that we have created in another floor of our hospital as a step-down unit. And I have to tell you that now in Italy, of course, many hospitals decide to do exactly what you mentioned, so to occupy OR beds. And this is another critical point, because by now we can't restart with elective surgery at all. Also, if we try to select, let me say, clean and positive pathway from negative patients' pathways also in surgical fields.
Can we find out where you got all your additional ventilators from? And is your oxygen supply to the hospital compromised, or is that comfortable?
Yes, this is again something that I forgot to talk, but let me try to, if I manage. So, anyway, you're right. This is a crucial point. Now in Italy, our government is getting a large number of ventilators, and so there's also some gap between the number of ventilators that we need and something which is, and what is available on the market. This is another issue. But of course, we are trying to map all the ventilators in our hospital, and no matter what kind of ventilator they are, we use all the ventilators that we had, and we have bought a large number of new ventilators, and some of them are available today, and some are being expected to be in the hospital in the next, next week. And oxygen supply is another big issue, because we had the problems with the oxygen supply sockets, because when you have 60 patients with 15 liters per minute at the same time in the emergency department, of course the emergency department oxygen delivery is not designed for that. Is not working in the in the normal conditions. So we had some problems, and we were forced to build new sockets. I mean, more or less 20 new oxygen supply sockets in the emergency department in order to ventilate patients in the emergency department. Of course, in the emergency department, there are only very few ventilators, so we decide to use a CPAP directly connected to the oxygen sockets. And this is not for sure, as I mentioned before, the gold standard, but it was sufficient in order to wait 1 or 2 days in order to obtain ICU or step-down units beds.
That leads us into another wave of questions we're getting here. You say there's a gap between the need of the ventilators you need and the availability of the ventilators. There's a lot of concern with ethical considerations. Are the admission criteria changing over time and what will happen with your next wave when presumably your beds have got fairly long-staying patients in them?
If I clearly understood your question, I mean, this is a very delicate question, because of course, if you are an ICU physician and you perfectly know what IRDS needs, you need to prone the patient, you need nitrox oxygen, you need driving pressure control, and all these issues. But I promise you, you can do that if you are in the middle of an outbreak. If your hospital is exactly in the heart of the problem, we receive 70 patients with a clear AIRDS. So this is something that in Italy is now under, the journalist and politician attention. And the question is, you have to decide who may live and who has to die. This is not exactly the right question, but unfortunately, what I have seen in that, which I have never seen before in my 30 years career, also is a sort of war scenario, where you have to decide where to put your ventilators, who has to be ventilated, who has the greater chances to benefit from your ICU treatment, and you know that you cannot warrant, you cannot guarantee the same level, the standard of level for all the patients, simply because you have not bed enough, you have not ventilator enough, and you have not physicians enough. This is another issue, because of course when you have 22 beds and you are by night during the night shift, you have 1 or 2 physicians that they are completely tired after 21 days of working continuously. Also, the treatment is not exactly the same comparing, let me say, in the peace period. So for sure, the answer is yes. You have to decide. You have to do the right things, but in a very short period of time, and you have to decide where to allocate, where to put your resources. I don't know if this answer is clear.
It's very clear, and I think there's a chill going down 1,000 spines in who are listening to it. But thank you for your honesty. I think that's very important for us. There's one final flow of questions that I'd just like you to address. In the UK, it's pretty clear that we're not going to be using high flow techniques when we're intubating patients, which is common in the UK now. But people are asking about high flow nasal oxygen and CPAP in the ward situation. And I know that they've been using it in China, and you mentioned that you've been using it in Italy as well. And there have been some concerns about potential spreading of infective particles. Have you got any comments about that?
Yes, I have no comments. I have to say you're right. It's for sure this is a concern. This is an issue, and this is something that everybody would like to avoid. But this has been the only solution when you receive 80 AIRDS in 12 hours and you are not prepared. You can cope with the gold standard measures. Otherwise, you are overwhelmed. You know, I have in my mind an hospital bigger than ours that totally collapsed in 1 day and a half. Why? Because they decided to wait for the swab result, and they use a CT with a large number of patients, and they have been forced to close the emergency department in 1 day and a half. So your concern is true. CPAP is not the gold standard in order to avoid the virus spread, but you know, that's exactly what we did. Of course, as some previous UK speaker told, the PPE and you know, your concentration in using PPE also in very critical situation is a key point, because definitely CPAP create aerosol. So so the risk of spreading the virus is quite concrete. But sorry, this is something that I would like to leave to you as a final message. In the very first hours, I try to do my job, referring to my, to the Italian Society of the Intensivist standard and to what is absolutely clear to me. But I immediately realized that if you receive too many patients at the same time, too sick, and with a critical cut in your team, if you try to be perfect and to apply all the protocols wherever, I'm afraid that this is not the way to go. The way to go is trying to survive, is try to guarantee the best standard of care for you, for the number of physicians that the number of patients that you have to take care and to protect your team with the resources that you have. If you try to do exactly the same because my ICU was 7 beds before, now we have 22, and they wrote me now 24. You can do exactly the same things, you can repeat the same protocol, you can't imagine to face this situation with your traditional tools. This is my humble opinion. I don't know if it's true, but what I can tell you is that around us some hospital collapsed in hours, and they did different choices. After 21 days, we are still working, and I think that this means something.
That's fantastic for you to give your time for this. Your talk, Dr. Storti, has been incredibly important, not least because it can be referred back to by other people and policymakers. We also have the president of the Association of Anaesthetists and the president of the Intensive Care Society, who are lobbying government for resources and so forth. So it's fantastic that you've been able to share that experience. So thank you very much.
Thank you so much for inviting me, and it has been, a great experience. And I really, I'm sure that you guys will do an amazing job, and be prepared for that, and you will be outstanding in doing your job. Thank you so much.
Thank you. Okay, so we're going to move on to Dr. Matt Davies. He's an elected council member of the Association of Anaesthetists, an anaesthetist and intensivist with a military background, and he's going to discuss elements of organisation, planning and logistics.
Thanks, Peter, and good morning to everyone out there. And it's an honour to be able to talk to you this morning. And following that very somber talk that we've just had, I'm going to take you through in the next 10 or 15 minutes what we've been doing at a sort of a local level and all the questions that we've been trying to address and deal with. As Pete already said, just bear with me a second. I just trying to advance my screen. Just struggling to move on my slides.
Try your keyboard arrow keys, Matt.
Okay, thanks, Andrew. Okay, that's great. Thanks. Get rid of the remote control. So what I'm going to try and cover really in these next 10 or 15 minutes is what problems have been facing our directorate this week, what have I thought about, what have I not thought about, which is a lot, and what do I keep getting asked, and how we're trying to address some of those questions. I'm the clinical lead for a intensive care in a large city general in the east of England, which is currently where I work and also practice. So, planning. So I came into work beginning of last week, with a sort of things of what I wanted to look at based on what had been happening in the news and also being circulated through the medical community, and was asked to start really sort of ramping up the planning. So we currently all have out there a pandemic plan in place, which was produced normally in most cases after the H1N1 events many years ago. And there was a perception at various levels within the hospital that we could just wheel that plan out and all would be well. I think what has become clear, certainly over the last week, and certainly in the last few hours, listening to the experiences in China and Italy, that it's a start, but it will be nowhere near enough. So we started to think about, based on the figures that were coming out and all the information that was being gathered, in our hospital and in our region, what sort of numbers of patients would we be expected to provide level 2 and level 3 care, in addition to the normal workload that we could expect. So we did some brief modelling to try and produce some numbers based on our sort of demographics of our population and what we could expect to see. And clearly, looking again at the presentations, it's becoming clear that modelling has produced a relatively low number to what we are going to expect. So based on that number, we then asked ourselves the three sort of key questions. Are we going to have enough space? Are we going to have enough equipment? And are we going to have enough people? And again, the answers are relatively stark. We may possibly have enough physical space in the building, but we will not have enough equipment and we will not have enough people to deliver the care. And one of the main purposes of this webinar this morning and other sort of information coming out of China and Italy is what we can learn. And we need to get all the information that they have gone through and use it to our advantage, if there is any advantage to be gained from knowing ahead of time what to expect. But there must be, and we must use that. So all little bits of information we can get will be very helpful. And that clearly came to the conclusion at the beginning of next week that we are not ready. I think one of the biggest challenges we all face, and I certainly faced at the beginning of this week, is how we're going to break down this current silo mentality that exists within hospitals at the moment, where everyone goes about their business in their own ways and does their own thing. And I think it's very clear that we are not going to be, within our directorate, it's not going to be ICU and anaesthesia, it's going to be one department delivering the same care, and we're going to need everybody to be doing the same thing. And that is going to also expand outside into other specialties, and we've already started to talk to the other directorates, the surgeons, the physicians, about what this means for them, because they seem a little bit behind where our thought process is on this. A lot's kept me awake at night this week, and clearly the unknown, we don't know, and that when you don't know, you can't come up with a solution, and I think that's a little bit of a problem. But we're getting more knowns as time develops. A lot of the advice, as it has to be from the Department of Health, because it has to be generic across the country, assumes that we're all starting from the same position. And the example I use here is the provision, the actual stocks of PPE that are actually in hospitals at the moment. And there is huge regional and national variation on what people have actually got on their shelves in their buildings. And then that can range from being very well stocked to actually some areas where there are no FFP3 masks and people to ask you to borrow them from other trusts. Again, at the beginning of the week, the standard answer was no, not yet. You can't have it. We are waiting to be reactive and not proactive. And the example I use here is how we're going to use novel ways to divide up our intensive care units and theatres, with possibly things like plastic sheets or some barrier method to provide an added level of safety in terms of donning and doffing of PPE. Only towards the end of this week have we managed to sort of start to get people to come and talk to us about what possible solutions we're going to have to create these extra bed spaces and provide a level of safety, certainly at the beginning, that meets the current standards. We talked a lot about this, the clinical dilemmas that go around in our heads about what we're going to do to CPAP or not, and based on what happened before in the H1N1 experience, where actually non-invasive forms of ventilation did seem to suit some patients. I think both this morning and what's coming out is that for many reasons that actually we may well not have the option of CPAP and NIV and high flow as a treatment modality. So it'll either be face mask oxygen or intubation. or as we've heard, potentially nothing. Where are we going to intubate these patients? Are we going to do it out there in ED or on the wards? Or are we going to bring them up to ITU and do it in our controlled way? I think there are lots of plans coming out nationally and regionally about what people have talked about, intubation teams going out or recovery teams going out, bringing the patient back and intubating an ITU. And I think we're going to be guided a little bit by what seems to become best practice on people's experiences and knowledge. I was lying awake at night thinking, am I just catastrophizing about this and shroud waving when I go to these meetings? I think probably I am, but for very good reason. And I think that's becoming extremely clear that actually this is going to happen. And I think very somber from what we've heard this morning. And I think actually towards the end of this week, what I've noticed among people who are not within the sort of our community is that people are starting now to really take notice of this in the hospital. So then I moved a little bit onto the logistics really, and sort of locally, what are we going to do? Clearly our most precious resource of staff. There are lots of things that could affect that even before we see the numbers of cases rise, where if there are schools issues or individual isolation and illness means we may not be able to provide what is even normal service up until the number of cases appear, and the impact that means is that we may well be using staff across the directorate to provide just normal care. Again, we talked a lot about PPE, and it is a big concern for a lot of people. So we sort of modelled what people have been talking about. So if we had one patient who was COVID positive, one nurse who did 2 hours on, 2 hours off, one doctor, one contact with one daily review and clinical interventions, and one visitor for 24 in a 24-hour period, we would use approximately 14 FFP3 masks for one patient for one day. Clearly, if that patient, the average duration of ventilation as we see is about 14 days in this patient, that would mount up to around about close to 200 masks. And then if you times that by our capacity to ventilate and the prediction of numbers with 50 ventilated patients, clearly we get very quickly to a number of masks that will be exhausted. You then add in things like proning teams and the benefit risk for that, and it clearly clinically appears that the evidence is good for proning, and we may need to include various other teams in doing that, but they will still need to have the appropriate PPE. Next, most important clearly is the drugs that we're going to use. So again, we modelled a little bit using 10 patients on moderate sedation, and we use propofol and alfentanil where we are. I think on those 10 patients on moderate sedation, we'd run out of propofol within about 11 days of various 1% and 2%, and we run out of alfentanil in under a day. We've got a national shortage of fentanyl. Clearly, there are other drugs available, morphine, midazolam, and vapors in theatre. But I've been seeking reassurances about the logistics chain, and clearly we need to be able. 10 patients on moderate sedation is a very low number, and I think we will need to ensure our logistics chain of drug supplies is robust. And we've been speaking to pharmacy about that this week. And we've talked a lot about sort of the physical hard equipment, the ventilators. We were in the process of changing our ventilator. Our new ventilator order is in and was due to be delivered in mid-spring. They are being built at the moment. My understanding for what is happening to ventilators is that they may well be distributed on a national needs-based level. But maybe Ganesh may mention more about that if he knows. But we are expecting to have no more ventilators than currently that we have in ICU, transport ventilators, and all the theatre and anaesthesia ventilators. We're clearly short of lots of pumps to deliver the care to these patients, a significant amount, certainly volumetric pumps and syringe drivers, which we're just trying to work out exactly how many we would need and where we would get them from. Clearly from those slides, you can tell we are not ready. So things that I didn't consider at the beginning of the week and are now playing on my mind, and we talked a lot about it, is the oxygen pipes capacity. So in my naivety, thinking that the magic oxygen tree would never run out, speaking to in detail how it normally works is that we have a relatively new build PFI hospital, and the oxygen capacity has never been an issue before. But what happens is that the oxygen runs out through the tank, and then at a certain point, when it gets to a certain level of capacity, it automatically sends a signal to BOC, who then will automatically send a lorry to top up your oxygen tank. So it's an automatic process. I think what I've tried to explain to people is that we need to be assured, and I know that again Ash will talk maybe a little bit more about this in terms of the national issue, that it is going to be the rate of drop of oxygen through as we increase the number of patients being delivered oxygen, that will be very difficult to predict, but also may not allow that time for that more automated message to get through to BOC, and then them to be able to deliver the oxygen when every other hospital in the country is in exactly the same position to supply our patients. And this is going to be, I think, more of a problem than we predicted. But I know there's more to come on that. PPE will or may run out. What do we do then? And I think that's a question nationally that we'll need to think about, and what level of protection is appropriate as the evidence develops. One might not be unique thing that you may have seen in your hospitals is that we're receiving new FFP3 masks, which are completely different than the FFP3 masks that we've been fit tested on. So therefore, I then have to be fit tested on another FFP3 mask, which may well then run out and then be replaced by a different one. And that clearly, every time we fit test someone, we use up a mask. So there is a sort of logistical anomaly there, where it would be very nice that we all receive the same FFP3 masks that mean that we don't always have to be tested and waste masks during the testing process. I'll come on to this, but it's not just about watching a video for PPE. It's about watching a physical demonstration. It's about actually be able to practice yourself. And I'll talk about what we're going to do about that next week in our hospital. The visitors policy, the national guidance is likely to be produced. It's likely to be extremely controversial with visitors, and it is likely to be extremely draconian in the fact that and views are wide across this about whether visitors, ranging from whether visitors should be allowed at all to whether they should be very limited. Because of course there are lots of considerations to consider. There's the visitors and patients needs to consider, certainly when their patient is potentially end of life. But then there is the visitor safety, the use of PPE, and the ability for the nursing staff to supervise the use of PPE in those visitors. So I think we are waiting for some national guidance on that. But it is certainly likely to be extremely difficult to explain to the visitors coming in why those policies are in place. One thing that it's clear that from what we've seen, about a third of the patients will get very quick acute kidney injury, and a lot of those will require renal support. And we just have not got the ability to provide that number of renal support to the patients. To give you we have 3 hemofilters on the ward. Based on the numbers we've thought about, we probably have to deliver hemofiltration to 15 patients if they were all appropriate for it. So there's going to be a lot of logistical challenges with that. The one thing to build into this, as we've already heard, and there seems to be some evidence coming out that the mortality predictions of patients who develop acute renal failure is extremely high, greater than 90%. So we're then back into the discussions around ability to provide care, to provide the best for most. And it's clear that at the beginning of the week, people did not think like me, but I'm hoping towards the end of the week, people will begin to have some sympathy with the way I think, and we're moving quite quickly towards where I was at the beginning of the week. What a lot of people are asking me, and we've talked about it, and Tim did mention it at the beginning, is the viral load going to be important for clinical staff? I.e., do we really need to think carefully about who, or actually will we have the opportunity to do so, about how many times certain people are intubating, and we need to have a regular spread out across lots of staff rather than just focused on one or two staff, and how can we address that? Big staff welfare considerations. Where can I sleep and eat if I cannot or do not wish to go home? For example, if you've got if they're caring for a high-risk relative at home and we've got no, and we can't, what do they do? And we've already, and I'll come on to some of the solutions we've come around about that on the next slide. A big question, I know a lot of people are asking why electives currently going ahead as planned. Now, I think that's a piece that's moving relatively quickly, and certainly with the cancellation of all elective work in Wales in the last 24 hours, I think the beginning of the week may well see a different track. And we already, from Monday in our trust, cancelled 3 to 4 lists a day, and the reason is primarily to provide staff with training, but also to start to free up capacity in the hospital. We've asked all staff to self-declare if they consider themselves high risk, and how we are going to use that information in how we distribute staff. A lot of people have asked me, can I go on annual leave over Easter? We are currently 20% of our workforce consultant workforce in ICU has probably disappeared in the last 24, 48 hours, as one of my colleagues has gone to Eastern Europe on his holidays, and from what I understand, those borders are probably now closed. And another one of our long-term locums was due to be with us for a few weeks. He comes over from Canada, has literally just probably had to fly back this morning because they were considering closing the borders. So there are very real considerations before we even started. One of the things that I'm looking at, sort of, and what we've done so far, as I've talked about, we're going to have a sort of regular ability to train anaesthetists, ODPs, theatre staff, trainees every day next week on clinical matters, on ICU refresher, on PPE, on fit testing. And currently, by the end of the week, we're predicted to probably have covered between 75 and 80% of all those staff will have that training. How we, from now, not next week, from now, how are we going to ensure we keep staff as well rested, fed, looked after physically and mentally? And there are lots of things I know. I won't go too much detail into that because I know Rob Self will talk a little bit about welfare in another talk. Back to PPE and a little bit of practicalities, clothing in and out of the hospital. What do we do about shoes? I don't know the answer to that. Initially started out, the advice was overshoes. That's not there anymore. Currently, people will be in the side rooms in our hospital in their normal footwear. I'm not sure that's a sensible policy, and we're looking at what we do about that. So one of I think the big benefits that happened last week for us is that every day there is a command and control meeting, as there is in most hospitals, but this is purely a COVID planning meeting in the morning. And we now have ICU anaesthesia, clinical director, one of us at that meeting every day, and that I think has really helped move things. I think not only have we been able to be reassured what's going on in the hospital, or not reassured what's going on in the hospital, but we've also been able to bring a lot of our thoughts and a lot of the information that we're gaining from our communities in China and Italy back on, and sort of bring some very focused directions that we should be taking. I think what's been absolutely astounding this week is the amount of rapid sharing of advice from everybody. You know, I'm sure like you, like most of you out there, I'm on 3 or 4 WhatsApp groups now, all completely dedicated to this. A regional ITU one, a national ICU leads one, a clinical directorate leads WhatsApp, and this is allowing very rapid sharing of our ideas and advice. Because if I don't know the answer to something, which is quite a lot, there is someone out there who probably knows the answer, has already done it, and has a resource to do it. So a lot of our education we're going to do with people we're using already education tools that people have provided from around the country. And I think by also doing what everyone else is doing, it seems in this situation, this is going to affect us all in very similar ways. And I think we need to be doing what everyone else is doing, to ensure that we've got a sort of one way to address this, rather than lots of individual people doing lots of individual different things. I think it's important. It's what's lacking, I think, and what concerns a lot of people, certainly non-ICU people, who may well be asked to do intensive care on a regular basis for the coming months, that we need some regulated reassurance to all clinical groups and specialties that no one's going to come back to us in the future and say, what did we do? Why did we do that with our clinical staff? Because there is absolutely no doubt that we're going to need all hands on deck for this event. Little things, we've ordered some webcams. I think the role of telemedicine within the hospital is going to be really important. It also may play a huge role in visitor and patient interaction, so that the visitors may not have to visit, or depending on the policy, if they're not allowed to visit, they can may well, whether there's an ability for them to at least see or interact with their patient, their relative in the early phases of the disease, if that's possible. Plus, it will also allow us maybe to sort of do some telemedicine across the hospital, if that's possible. So then, and that also comes with asking IT to make available bandwidth for the Wi-Fi, so that there's not an unnecessary clutter, so that important things can get done via this method. This I put on before, but may also be subsided by what the Chief Medical Officer's briefing yesterday was, that actually one of the key things that we're going to need to keep people in work for as long as possible, if they're well, is to the testing healthcare staff to minimise the time off work. And I'm not sure of the position of this, and maybe we'll be able to clarify this on the joint website. Is that currently, if you self-isolate, it would make sense if we could test certainly the priority staff quickly, get the turnaround, and if people are negative, allow them to come back to work at that point. If they're positive, clearly, or unwell, they take exactly the same as everybody else. But there must be consideration for prioritising testing healthcare staff. My understanding from yesterday is that prioritised testing will be offered to intensive care staff. There are a little bit of conflicting information comes out that even if you're testing negative, you still have to self-isolate for 7 days. So I'm not quite clear what the position on that is going to be. Hopefully it'll be more clear over the weekend. And I can't come back to this enough. It's the most precious people we're going to have is going to be our staff, and we're going to have to look after them from now going onwards for the next 6 to 9 months at least, I would imagine, because there is going to be a huge period of recovery needed after this. And I know Rob South's going to cover a lot about staff welfare. I know a lot of resources already out there, but it has to be at the forethought of how we prepare for this. So I've kind of moved from a position where we're not ready to a position where we're almost ready. But I do caveat that with a huge but, in that I don't know actually what we're almost ready for, and we may well never be ready for what's coming. Thank you very much, and as I echo everyone else's thoughts, good luck to you all.
That's great. Thank you very much indeed, Matt. There's, as usual, a huge deluge of questions which I've tried to condense down. I'll just make a comment first when we're talking about renal support. And this is just something that we've done locally, and that is talk to our renal physicians in the dialysis unit. And it appears it's complicated, but it's possible potentially to utilise some of the 20 hemodialysis machines that they had. It's not completely straightforward, but that can be used in a sort of American way of 3 hours of dialysis every couple of days. So that's a possibility. But as Matt says, the outcomes seem to be very poor from that. One of the questions that is coming up a lot and is about elective surgery, which it appears in many hospitals seems to be going on as normal. And one of the comments that comes with it, says, can this webinar be available to our senior management? And I think I would suggest that when the listeners go back to their hospitals, they get their chief executive to listen to some of the talks on this so that we can have a reality check. But a question for you here, Matt, is a number of people, when you're talking about the pumps, are saying, are we planning to, or some people are planning to, and some are asking about it, using isoflurane for the sedation in the operating environment when patients are being ventilated there?
Yeah, absolutely. Thanks, Pete. Great. And we certainly have been talking about that a lot, because our current first expansion plan is clearly into theatres where we are in terms of for the ventilated patients. And I think we will almost certainly be using vapours that we have to preserve the sedative agents that we've got. I am not aware of any clinical evidence of harm or benefit actually using vapours, so that to me means that it's just as good to use vapours, and actually we have plentiful supply of those currently. So yes, I think once we get to that phase, that we will almost certainly be using a significant amount of vapour for sedation.
The next theme of questions, someone has said, sounds like we're all going to be completely overwhelmed. Is it sensible to be doing transfers in the early phase, or do we just keep expanding? That might be something that Ganesh will comment on at the end as well. But Matt, what's your thoughts on that?
Yeah, so that is, we have talked about that a lot, and actually, practically speaking, having with my background from the military and the logistical planning of moving mass casualties around places, I think we'll very quickly, certainly within our region, approach a period of stasis where nothing will move anywhere, and notwithstanding also the risks of moving infected patients with lots of assets around the region. Yeah, I think I'd be very interested to see if Ganesh has a view on that and what the national view is, but I cannot, once this is established, I think we will just locally expand until we can't anymore, because there will be we will all be shared in the same situation. So it's not that there'll be a hospital just down the road that will be empty waiting for us to transfer patients into. That's my view at the moment, but clearly I think that's one thing that will develop over the coming days.
That's fantastic. I'll stop you there, but that's been very, very useful. We're going to be running over a little bit with this, and I think we'll have no apologies for that, because I think it's very important. The next speaker is Dr. Robert Self. He is again an elected council member and chairs the Wellbeing Working Party at the association, and is a consultant anaesthetist at the Royal Marsden Hospital. And Rob is going to do, I think, about 5 minutes of slides, just priming us, looking at welfare while all of this wave of patients come across us, and what's going to happen to the staff. Thanks, Rob.
Hello, can you hear me there?
Yes.
Yes, brilliant. I'm just sorting out the technicalities, and there we go. You can see my slides okay?
Yes.
Yes. Okay, thank you. Thank you, Peter, for the introduction. I have spoken about well-being on a number of occasions before, but I've never anticipated myself speaking about something like this. So in the next 5 minutes or so, I'm just really going to talk about why well-being will be important. That's really self-evident, I think, from what we've heard from the previous speakers, but also to talk about some resources that you may have already seen, and also recognise that this is going to be an ongoing thing. I think, as Matt Davis and others said, we don't know how long this will go on for, but it's going to go on. The well-being implications could go on for a very long time. I don't have 100% of the answers. I might not have any of the answers, but as I say, I think these resources are important to share. So I think it's really about individual and organizational things and seeing what's out there. So Matt alluded to this excellent intensive care society resource, which I found last. It's available freely on the website. It's 2 sides of A4, and it's got lots of practical suggestions. It's by Dr. Julie Highfield, and I think the most useful was a recognition that this is an unprecedented situation. Undoubtedly, everyone is feeling stressed, but it is okay to not be okay, because this, you know, we've never faced something like this before, or many of us haven't. And in the document, there's this whole range of potential psychological problems, and we've heard much about this from people who've experienced it in the form of Dr. Song and Dr. Storti already. At the moment, we're at the top of this slide. So we're looking at the anticipation, maybe feeling a bit overwhelmed already. And, you know, are we ready? We've heard understandably about concerns of risk of infection as healthcare workers, acknowledging that, you know, this is the profession we chose, and also being worried about transmitting it to our family. From what we've heard from Dr. Storti and others, I think the words he used were a war scenario, and psychologists have talked about moral injury. So feeling, you know, you're in a war zone, or you are in a war zone, and not being able to deliver the care that you would have delivered in peacetime. And then exhaustion, workload, and then later on post-traumatic stress disorder. As has been mentioned, I mean, to get through this, the staff are going to be key, and managing chronic stress and the poor mental health of staff is mentioned in this WHO document, which is also freely available. And no one will be able to fulfill their roles unless we get on top of this as much as possible. We should also acknowledge that some staff may already have pre-existing chronic stress or mental health problems, and obviously this isn't going to make things any better. So from an individual point of view, what can we do? And once again, these are from the ICS document. We certainly can't control what's happening. It's out of our control. What we can control is what we see of it in the media and so on. And without in any way burying our head in the sands, we don't need updates every 30 minutes, or we can come off social media. And this might be an important thing. As we've said, feeling stressed is entirely normal and not a sign of weakness or being unsuitable for the job. In these difficult times, we're not going to be able to find new strategies to cope. We're going to have to use things that have worked for us in the past and avoid unhelpful strategies, such as alcohol, drugs, and so on. Previous speakers have alluded to the importance of the basics: rest, food, and exercise. Many of us know that in times like this, we have reduced bandwidth, so we can't do things that we'd normally do with ease. And we've got to just remember that. And also remember that the way we talk about things, we can't hide what's happening, but dramatic language can have an effect on ourselves and colleagues. Some of you will have seen this kind of thing about a pyramid of well-being, and by Shapiro and colleagues. And I think more than ever, we're going to be very much at the bottom of the pyramid, the basics. You know, we've heard about people working 18 hours, you know, getting hydration, getting food, all of that stuff is going to be very important. For the organization, communication is going to be key. and also looking at allowing healthcare workers to look after their family members. As much as possible, non-essential tasks shouldn't happen when you're preparing, and as things evolve, that will have to be constantly looked at. If senior people in the organisation can also model the "it's okay to say you're not okay," that is also likely to be helpful. And I also referenced this JAMA online article, which has some useful additional things in it and is worth a look, freely available on the web. So those are the resources that I've mentioned. There's also something about the psychological effects of isolation and quarantine from the Lancet that's just come out. And that's in no way saying that, you know, that's not important, but it does have psychological effects. So my take homes, it's unprecedented. We're all in uncharted territory. We're almost certainly going to need to look at what's worked for us before. We've got to look out for our colleagues and leadership and organizations. We need to support them as well, but they also need to look out for the staff. I'm going to leave it there. Thank you.
That's fantastic. Thank you very much indeed, Rob. I'm not going to take a lot of questions on that because I'm very conscious that we're running over, and that was very comprehensive. There was one question here from Jane saying, do we as a profession think that the government need now to increase the social isolation of the public in the at-risk and comorbid groups? Is it worth a vote while we're on line and perhaps feedback to the government? Andrew's going to add that as a poll question for the review afterwards, if you wanted to just get a unscientific but a fairly good number of relevant people voting on that. We're the end user people from the point of view of we're the one that's going to take the brunt of these poor people coming into us. Okay, I'm going to move on to our president of the association, Kathleen Ferguson, who's going to talk a little bit about leadership and ethics. So thanks very much, Kathleen.
Thank you very much for the introduction, Peter. No pressure. Thanks to everybody for being here this morning, to our organisers and moderators and the technical support. It's superb to be with kindred spirits. I have no conflicts. I have very few credentials, but I have lots of observations. And what I want to deliver to you in probably the next 2 to 3 minutes is a simple rallying call. I want to bring to your consciousness how we might enable ourselves and our colleagues to deliver good, in fact, great quality care. And in doing so, I'm just trying to move my slides on. There we go. I wanted to cover 2 things, leadership and followership, and I'm going to bring in this topic about non-clinical decision-making dilemmas. So if we move first to good leadership, what does it look like? Good followership, why is it necessary? Leadership's about helping people to get from where they are to where they want to be, and we've heard about the gargantuan task that we have ahead of us in the next coming days or weeks. If you set a target to a group of people, a few will move towards that target and they will take others with them. If we add to that a social or ecological pressure, then what we find is that we develop a leader and follower pattern. It's all about coordination and collective action. It's about one or a few, steering the behaviours of others. And for that to happen to its very best, what we need to have are shared values, shared goals, mutual respect, but above all, shared information. Information is power, and power is information. Our leadership needs to be adaptive, it needs to be flexible, it needs to be distributive. It's not one leader at all times, it's the best leader at the right time. If we move to, I'm going to bring in non-clinical decision-making dilemmas, because we know, and we've heard already from Dr. Sorty, that when we start to talk about the clinical decision dilemmas, we start to get into very, very difficult territory. And I'm not suggesting for a moment that we shouldn't go there, but perhaps we can develop our strategies by looking at some of the non-clinical decision-making dilemmas that we have already, some of them having been alluded to this morning. So it's uncharted territory. The GMC's guidance says that we're in highly challenging circumstances, that we may need to depart from established procedures. But in doing so, we need to follow the principles of duty of the doctor. And that includes needing to work cooperatively with colleagues to keep people safe. And in keeping people safe, I think we also refer to ourselves and our colleagues and our families there. So I've written a few non-clinical decision dilemmas here, and some of them we've actually spoken about already this morning. So here's a colleague who's pregnant. So, and she's anxious about raising this topic with her clinical director and her departmental colleagues. She's afraid of stigma, she's afraid of not stepping up to the mark, she's afraid of how she will be viewed after the crisis. What do we advise her to do? So we know that Rob has highlighted, steered us towards some of the resources online around about these issues. So for pregnancy, we could include in there, or we could swap in there, chronic ill health. The occupational therapists have and clinicians have provided for us guidance. It's quite clear that pregnancy affords no greater risk. However, as a department, as a clinical advisory in your department, you might feel differently towards a 34-week pregnant woman who may currently find herself in the front line of delivering intubation to these critically ill patients. If we move to the next scenario, here's the very case that we heard about earlier, where we run out of PPE protection. So, and we've already heard in the media about clinicians who have decided that they're not going to turn up to work if their employer does not provide for them the tools to keep them safe. So what would you advise your colleagues here? How would you respond to this threat? If we leave these decisions to the very time that the problem faces us, then we really have missed the boat. And I'm suggesting that actually your clinical advisory group should be practicing these scenarios in simulation, just as you practice the simulation of PPE. Another scenario, here we have an anaesthetist, because we recognise that we're slightly different to the situation in Italy. We have separate training programmes, we have anaesthesia, we have intensive care medicine. Here we have an anaesthetist who is quite prepared to deliver the intubation on the front line, but they're much less happy about the difficult care of a patient in an intensive care scenario. What are we going to do about this? How are we going to be organising our departments around about this? So what I'm suggesting is that we need to bring our clinical advisory groups really to the fore here, and that we need to add into that a local ethical group that supports us in making these difficult decisions. I'm not suggesting it's the same group that does clinical research ethics discussion. I'm thinking about a new group that we pull together now. We have 15 days, 10 to 15 days to get ready, new groups together where we sit down and address these difficult decisions so that we know where we're going, so that we can concentrate on the clinical care when the time comes. And I'm going to suggest that Peter Young might tell us a bit about how they've done this in King's Lynn. So in summary, effective leadership and followership supports good clinical care. To do that, we need information, we need a sense of control and of ownership. These are key. We need to empower our clinical advisory function, and we need to support that with good ethics. I commend this to you. Thank you.
Thank you very much, Kathleen. I think I was the one that was meant to be doing the questions, and you've put one to me. So I mentioned to Kathleen previously about in preparedness, we've set up an ethical support group in the hospital. We believe that much of if all the intensivists are taken up with the 100 patients that come through the emergency department door, they won't have much time to be looking after the patients in their ICU. But we do have experienced medical specialists within our hospital who make these sort of assessments and decisions all the time. So we've set up an ethical support group which has a medical chair, the legal lead for the trust, patient representation, crucially board representation, because I believe the board needs to know exactly what's happening on a day-to-day basis to have some corporate responsibility as things move forwards. And we also have bed management there, so patients that are being presented to us for further assessment have a bed created in one of the slots outside the footprint of the ICU for us to be able to manage it in. So that's what we've done in answer to your question, Kathleen. There's been a number of comments from pregnant consultants and trainees, and there's I don't know if I can really condense them down, but basically there is quite reasonably a huge concern that they may feel that they are put in harm's way, and quite rightly will have will have concerns and an instinct to protect their babies. Kathleen, can you respond to that question?
Yes, so the Royal College of Obstetricians and Gynecologists and the Royal College of Paediatrics and Child Health have produced some guidance. There is no evidence that pregnant women are at any higher risk than anybody else in the population. So that's a fact, but actually what does it mean to us in practice? And I think that we as a group in your departments, if you look at your colleagues who are pregnant, they are definitely in a vulnerable position. They not only have to protect themselves, they have to protect their unborn child as well. And that's why I think that we need to come together and consider these ethical problems. My own personal view is that I would not suggest that my pregnant colleagues should be frontline intubators in this situation. There are so many jobs that we can be doing. It doesn't need all of us to be stepping up to that plate to intubate these patients. And I think we should be addressing this now and affording our colleagues even the slightest piece of protection. That's my personal view.
And I think I'll just echo that from the perspective. I think all of us have realised the huge workload of stuff that can actually be done remotely as well, writing up the guidelines, sorting out the data, and so we can put people in appropriate positions. But everyone will probably be able to contribute in a way.
Peter?
Yep.
It's Tim here. Can I add that in the guidelines which we've drawn up in the last week, which I hope will go on that hub website today, that we specifically have a section addressing considerations as to who should not be involved in airway management, and that does include mention of pregnancy.
That's really helpful to put that in at this stage. And as Kathleen said, one would have hoped that those local decisions would have been made sensibly, but there's nothing like having it in a formal joint document to encourage this practice across the country. I'll move on now, and thank you very much indeed, Kathleen. And we've got Ganesh next, President of the Intensive Care Society, and he'll address you now.
Thank you very much. Thank you very much for the invitation. It's a real privilege to hear Dr. Song and Dr. Storty speak in particular. I know they've gone by now, but also I think the diversity of the UK speakers shows that this is very much going to be all of us working together, which I think is a very strong message. Fine. So thank you. So part of mine sort of follows on from Matt's, and just giving you a little bit more generic information. I'll mention a few specifics, and actually I've got a couple of things at the end which may address some of the questions that have been raised so far, actually. Although I'm not necessarily the best person qualified to speak about them, including the epidemiology, but I'll just give you what the information I've been given to share with you. So firstly, just beginning on readiness and following on from Matt's talk. Just as a brief history, I think this seems a very long time ago now, but there was a period, probably a couple of weeks ago, when we were sending any proven confirmed positive patient to the high consequence infectious disease centres. There have been 4 of them for a while, Royal Free and Guy's St Thomas's, and then Liverpool and Newcastle. That very rapidly turned into an expanded base, and at which point the plan was still to send confirmed patients there, but people beginning to worry about, what if I have a patient on my unit that's not confirmed and we have them there for 24 hours. Again, that seems a long time ago. We're now at the stage of stay put. So patients that are positive and on ventilators are expected to stay where they are unless there is clinical benefit in moving. So while there's capacity, the acute respiratory pathways, referrals for ECMO and so on obviously still apply. But we're no longer sending people elsewhere simply because they've got the virus. So this is kind of where we are now and where we're going to be next. I can advance my slide. Okay. Is those ITUs will be expanding, and those are the things we've been talking about so far. Just to sort of give a bit of insight onto that and give a context to Matt's talk. So we have a little forum going inevitably. So jointly between ourselves and faculty, but the other major power in UK critical care is obviously now WhatsApp, and there is a UK-wide ICU leads group, and we took the liberty of surveying them on a few things, which I thought I'd just share with you. So how's your trust planned for ICU expansion? So here, green and blue are generally good. So green is planned and done. Blue is plans are in place and we actually walked through on them. Orange is somebody writing on a bit of paper, and the no plans is worrying, but a small minority. So most people have at least planned. Have you have your trust plan for creating more isolation rooms in ICU? So a bit of diversity there, but again, quite a lot of people planning and executing or walking through. And to put that into context, so this is, we've got 2 ITUs in my hospital, not because we're huge, but just because they were built far apart from each other for obscure reasons. This one, the newer one, we've essentially abandoned and moved everything into, so this is the old unit as it was, I think, last Tuesday or Tuesday before. 24 hours later, we were installed in what was a newly built, recently newly built 15-bed negative pressure infectious diseases ward, which they kindly vacated for us. And so we've been able to expand up quite quickly. It raised a few issues, as you can see there. You can see sort of like something that looks a bit like hostage photos with ransom notes stuck on the window. So this is kind of issues with communication that Matt touched on, and trying to cram ITU stalls and supplies into a ward that wasn't built for us. So not been entirely straightforward, but we've done that. Here are some of the, we've got some nice shiny pads for communication, which listening to the talks, I think clearly going to be useful for patient-related communication. Other ways of doing it, this was the Chelsea Westminster unit, which was open, being converted into a series of side rooms. So your mileage may vary as to how people go about this, and some people clearly can't, but people are doing things to try and increase isolation in level 3 areas. And as you can see from the numbers here, they're non-trivial numbers. Do you have plans for cohorting patients? Again, green and blue is yes, broadly. And do you have plans for using non-ICU staff? Are you beginning to deploy those? Are you taking steps forward? So in this, I'm just going to refer to something that Kathleen done. So some of these I've, I don't know if this works for you, but as a way of sending people onto websites, I've put QR codes in so you can screenshot and point your phones at them, or do it now. But just importantly, so this, the first one is from the GMC website, and they made their own sort of further statement, but also prior to the statement that Kathleen referred to, I think, there is a joint statement from all the statutory regulators, including the NMC and AHP bodies. So basically saying that we expect people are going to be working differently, be sensible, but you won't be struck off simply for doing something outside your traditional role. It really depends what you do and how you do it. Similarly, the colleges and the faculties have come up with statements suggest, along with the AGBI, saying that actually they encourage and support anaesthetists working across borders. So there's a lot of support from the regulatory bodies and hopefully from within trusts as well. So this just is a reassurance. Just to go back to the survey, and I know this is a topic of some interest, and I'm going to comment on this shortly because I think things are going to change next week, and I'll tell you why. So, is your trust planning to reduce or stop elective surgery? A little bit of diversity, some already have. Mine is beginning to. Have they stopped for operational reasons to prepare, or have they stopped actually for training? And there was mention of doing the stop theatres in order for training, and a lot of trusts have actually done that. Some still haven't done anything, and I think some of the audience will still have. I think, as has been alluded to, trust executives who don't get it essentially, and think this will go away or just be flu or whatever. Clearly using materials here to persuade them is useful, but I think there'll be other messages coming as well shortly. Wellbeing and psychological support. So a minority of people have kind of setups for it, but obviously everyone's interested. Kathleen very kindly referred to our materials. So some of these actually predate, a chunk of them predate COVID, but Julie Highfield, the original author, has also updated with a COVID specific update, which we'll put out onto the joint site as well. This is because that's not linked yet. This is the QR code for the site on the ICS site. And subjectively, so we asked people, and we had 100 replies to this, 105 this morning. What's your sense of urgency in your trust? You know, coming from other people, where 0 is comatose and 10 equals your trousers are on fire. And the responses sort of varied, but it comes out the weighted average about 6.4, which is a sort of 2/3 urgency, to put it crudely, which is kind of reassuringly British, but is, I think, would agree, insufficient. So there needs to be a greater sort of heightened sense of urgency around this, and it's geographically disparate, not by region, but just between trusts. So that's at trust level. Organisationally, I'm going to try and rattle through this. So obviously we have a multiplicity of bodies. I've put the ICS front and top there just because I can, and I'm doing the talk, but actually these are all very much equal partners, and that's the way we would like to be seen. I'm sure Peter would agree, that we're all working together. So there's not only a single hub for information, that people need to feel reassured that we're taking a common approach to all of it. This is the site that's been mentioned by Tim and others. So it is live. That's a QR code for it. The actual title of it is a little bit unwieldy. So I've taken the liberty. So the tiny URL bit at the bottom, if you're listening to this sort of in the car, is just tinyurl.com/4bodies. And I just made that up this morning. So I don't claim any legitimacy for that, but it's just a quick-handed way of accessing that website, but it will go through to the original site, which is ICM Anaesthesia COVID-19. So this will be the hub for all the societies mentioned there to submit their materials, and so that you're going to one place for everything. On an organisational level, obviously there's a multiplicity of bodies involved as well, and we've already seen that in terms of Public Health England being involved in PPE, NHS England, you know, does guidance come out through NICE? What's Department of Health doing with its nerve tag group? I think to sort of cut through that, and I'll say, and to sort of leap ahead a little bit, NHS England, I think, is taking direct command over this. It's now declared a level 4 incident for the NHS, and in terms of command and control, the NHS England can come and commandeer any resources they want, ranging from your parking space and your stapler through to any other NHS resource. So that they would say they are the definitive source for this. Obviously, lots of things are linked to NHS England, including the CRG, but that I won't sort of bore you too much with that. But what I thought would be useful to do, and this is a bit of a sort of movie trailer, because I know these are all topics people are very keen to see things on. And I'll just flag up what's coming in some cases in the next day or two. So I'm speaking on the Saturday, the 14th of March, and there are things going on all of these really over the weekend. On the PPE front, I'm just going to skip a slide there for a moment. So the definitive source for this is the Public Health England, or what was Public Health England site, but through gov.uk. Again, I've done a tiny URL, which is COVID PPE, and a QR code. The actual source site is on gov.uk. That page, even if the contents change, remains and will remain the definitive link for anything to do with PPE. So I would encourage you to sort of keep hold of that. And if you're worried about any variation, just keep going back to it. This table, I think, which I was sent during this morning's session, is in that document. That document there with the red COVID-19 actually appeared last night. So we've changed from somebody's changed from the gov.uk format to a 49-page PDF based on the Scottish guidance. But this is now taken as definitive, and as you can see in the small print, is signed off as such. So keep an eye on that. That does include things like, do you wear an FFP3 mask inside an ITU room, whether or not you're doing something aerosol generating? And I think the answer here is yes, you do, because it's regarded as that. So this is definitive now, and I'd point you to that. I'm just going to go back a bit. So legal and ethical has been touched on by Kathleen and others. I'm going to be very sort of cautious about this. Clearly, there's a lot of hunger for the full guidance. Clearly, also it needs to be right. Something I think all the attributions below at the moment, NHS England through the CRG is looking at this with a bit of some clinical input, and I've put it as ICS Plus partners just because I don't necessarily have all their agreement to put their names and logos on there. But I think we'd all agree there needs to be professional involvement in it. And just to give you a very general steer, which I don't want to sort of misguide people, but at the moment it's regarding a few things. So firstly, as has been touched on, things that should be being done already should be done. So discussions at the front door with people appropriately about what they would wish, and escalation planning. The things that we would have said last winter need to be being done regardless of coronavirus. Now is the time to make sure those are done, because that's not something that's extraordinary and due to the virus. That's something that should be happening that just isn't yet. As things progress, I think what's being written at the moment is a sort of framework statement that acknowledges that the ethics of the decision making around this must reflect the situation at the time, including resources, and also acknowledges that these things are not the sole decision of one person. So it's very much around working together within a defined framework with good documentation. I'm really not going to say anything more than that at the moment. I know people are desperate to see something. I think one thing I would take the liberty of saying is, certainly from the ICS point of view, and I think from our partners, we are not keen on the idea of a sort of reverse triage based on a physiology score or something equally cut and dried. I know some regions have gone down that route. I would encourage people to sort of wait for the guidance that's coming out via NHS England. So I'll leave that there. On regard to the NIV topic, again, this is currently under the NHS England group. They've got BTS on board, because it involves patients outside ITU as well. And there are different elements to this. One is around BiPAP and high flow nasal oxygen being aerosol generating procedures. At the moment, from the PHE and from the public health guidance, though you can do it, but do it in a side room, preferably a negative pressure room, and treat it as an AGP. So staff should be in PPE in that area. There are other issues as well, including the issue of oxygen supply, which is not something we're used to thinking about as intensivists and anaesthetists. We just plug stuff into the wall and expect things to happen. But actually on the scale people are talking about now, and as has already been mentioned, there is no guarantee that's going to be adequate, or that it won't run out in a matter of hours rather than days, and there is planning around that. But part of it is also what kit we use determines some of that as well. So that will come out. It's being drafted literally this weekend and being discussed. The other guidelines, again, this is just sort of trail things that are coming up. The first one Tim's already spoken on and will be coming up on the joint site. Thanks for that. The people ask about antivirals. And I'm just going to mention on research here as well. And again, I'm relaying information from other people just to give you a very sort of overview things. So I'm not a virologist or an expert in any of this, but just to these are things people are happy to sort of pass on. So currently there are various things. So research-wise, there's no specific anti-COVID trial, but there is research relating to it going on. I'll come on to that. In the meantime, there is a discussion again this weekend between the people with HSID expertise coming up with pragmatic guidance for compassionate use of drugs that are already available. I'm not recommending these by listing them. I'm just mentioning them because you'll hear them. So remdesivir is available in very tight quantities. It's got a very narrow sort of window of opportunity in terms of being sick but not too sick, and it's under the tight control of Gilead, who make it, limited supplies worldwide. And at the moment, those are the indications would include single organ failure only, no raised, I think ALT less than 500, and no cardiovascular shock. The way I'll come on to how to access that on a compassionate basis, strictly only over the next couple of days, pending guidance. Other drugs have been mentioned, such as Coletra, and I think the general feel is that by the time they get to ITU, it's too late for those. But again, I'm not qualified to comment on it. What I will do in terms of process is say that there is some work going into pragmatic guidelines for a top 5 things to consider. but that's recognizing there is no real treatment for this. It's what things you might want to talk about. The advice for now that I was sort of given to pass on is for remdesivir, if you think you've got a patient that's in those categories, phone a friend, and by that, your local friendly HSID centre. Now, if you're working at one and you've just indrawn your breath sharply, this is strictly only for the next day or two while stuff comes out. But for the moment, it makes sense to phone somebody you might know and see if there's something that could be referred. On a more research-based basis, there are things going on. So the AIRWAY framework is something where for you to know and plug into. There is a coronavirus-specific aspect to that, which is a coronavirus clinical characterization consortium to understand the transmission, prognostication, and ongoing for this disease. It's an existing framework. It will be known to your trust via the research department. It's being so the lead person for this is Ken Bailey up in Edinburgh. Have a look at that website, because I'm not going to give you a sort of coherent summary right now, but these are patients that will come through, mainly having been recruited by infectious diseases at the front door of the hospital. But if they come through to ITU, it's important that we continue to take samples and continue to characterize the disease, because if we don't do that in a systematic fashion now, we'll lose a massive opportunity. In terms of how that happens, all the research nurses and other people in the hospital will be retasked. So there'll be cardiology research staff and others around who are going to be repurposed for corona-specific things by those involved. So what we need to know as anaesthetists and intensivists is keep an eye out for this. If you see something called AIRWAY, it's essentially a very elaborate surveillance study, and if you've got a patient on it and they come and we let them drop off the net, then that's crucial amounts of data being lost. There needs to be some thinking about whether a research nurse is the best person to don PPE and go in and do consent if it hasn't been done already, or do samples. So we need to work with them, support them. There is a new trial coming out for which the name and the funding aren't confirmed, about treatment for people needing critical care, and I haven't got any details on that, but that's an announcement is imminent. And then the existing AIRWAY CAP study, which is a platform study, which is all set up and designed to be able to add arms to a respiratory infection study, and was specifically planned around a future pandemic to activate quickly, is there and has antiviral and steroid arms to it. And that's about making people better once they're sick. So those are the research directions. So AIRWAY is around characterizing the disease. The second one is a new trial around treatment, and then the AIRWAY CAP is around making them better once they've become sick and come to us. So keep an eye out for those. Also on the research side, there is a lot of, as those on the WhatsApp group will know, and I'm sure you can know locally, there's lots of guidelines or local guidance coming up. And I'm sure we'll look for those. These all look great. How do I sort of characterize and validate these? Which ones do I use? There is potential work to be done on that. So again, Ken Bailey, Edinburgh is a major informatics centre, one of the top 4 in the world. They want to use AI to essentially analyze all the guidance out there and then come up with a human written sort of synthesis of all of it. So this is a plea that anything you've got hold of, please send to this email address, and it'll be fed into Skynet essentially. And but I just want to put that in front of your radar as well. I'm just going to move on to the last bit. So this has been declared as a level 4 incident. So NHS England can take command of all NHS resources across England. I'm not sure how that interacts with the other nations, but there's just in terms of level of severity, this is the highest level you can get in terms of NHS activation. And maybe a little bit of stuff that had been sort of sent from that, but in this context, what I would say is there is going to be a major communication across the NHS next week, which will reset, I think, everyone's understanding of what this is. So anyone in a far corner that thinks this isn't anything real is about to get a bit of a shock. I won't tease or spoiler it, and the final format may not have been decided yet, but there is going to be a major communication on this to tell everyone what the scale of this is expected to be. In terms of what's known from the work sort of feeding into, I'm just going to mention a couple of things. English experience so far, most people have had mild disease, day 6 to 12 is a worry period, rapid deterioration. There doesn't seem to be an awful lot between being well and deteriorating and ending up on ITU or on a ventilator. As has been alluded to, the thinking is we won't necessarily even be doing ITU in the way that we think of multi-organ support. It'll be ventilating or not ventilating. And as the numbers have increased, the sort of containment's moved on to self-isolation. The clinical picture for China from the data people are getting from there, and again, this is not something I've seen directly, I'm passing on information, but it appears to be similar to viral pneumonia, and that's from 5 years worth of ICNARC data. So the pattern clinically seems to be like viral pneumonia most closely. and without an awful lot added to that in terms of other organ failures. So the focus now is just to maximise ventilation surge capacity, and you can see there a third of beds for ventilation, which might be an eye-watering figure. So it's basically doubling what we've got now and doubling it again. And obviously there are going to be questions about machines and supplies and oxygen. There's a variety of work going into that, I believe, including slightly non-conventional things. I'll leave that there for the moment. And then there may be some stockpiles, there may be use of other mechanisms to provide that. Preparations that are going on nationally, again, I'm not involved in this, but just reporting. So BOC have been asked to quadruple their production. As others have alluded to, getting it to the hospital in time for that hospital to not run out that day is a challenge. The number of tankers has been doubled. Drivers are being drafted in from elsewhere, including the military. There is work going on about maximising the number of ventilators and NIV equipment, although I'm not sure how that squares with what we talked about, maybe for home NIV. And there are guidelines. So he's mentioned this. I'm not going to go back to this topic about thresholds and ceilings of care. But there's an understanding that basically, if we go into maximum surge, it's going to be a single organ respiratory support. And I won't get into the ins and outs of that, but just as a flag for how seriously people are seeing this in terms of volume. They've mentioned training and challenge there. This is an NHSE slide, but actually I think we know we're all beginning to think about these things. And I think the comment there ties in with one of my previous slides saying there's no new drug treatments currently planned, but there are other than in research. So a question for the group, I mean, this is from a different talk from a different person, but I've relayed it, is getting a feel for the approach used in other countries. Is ventilator use going to be between 2 and 4 times normal? What have we not asked about? I mean, what I'm going to do, just briefly, sort of with permission, is show you this, which was sent through this morning in redacted form. And I think this, so I'm not an epidemiologist and I'm not, Chris Whitty's spokesman, as it were, so I don't want to misrepresent anything, but just for information, this is the rationale behind the current strategy. So this is what this black line is if everything hits all at once with no mitigation, and that's what we're trying to avoid. If you say the line of maximum ventilatable people is here, I don't know if you can see the cursor there. This is what would happen if we did a bit of moderate transmission reduction. This would happen. If we did the whole Hong Kong, Singapore model of completely clamping down, which I know from a colleague who works in Singapore, I think is the case. They're in a sort of steady state, which she's sitting there with 8 people in her ITU. They're completely cohorted. They're working regularly. They're under strain, but there's a feeling that they've got to a sort of steady state. So the thinking behind that here is that if you do that, there's going to be a massive spike in autumn, and that might be the case in other places as well that seem to have good control. So the plan here is the brown line. This is a document that went to COBRA for sort of cabinet level discussion and decision. So, and it lies behind some of the discussions you've seen. I'm not here to front it up or to defend it or to anything, but I'm just giving it because it was passed on as being okay to provide, and it may just at least show the logic behind some of it, which is that if there's a moderate amount of mitigation, then what will happen is there'll be a slow rise, hopefully within some sort of sensible ability for us to provide surge for, although under extreme circumstances. But also importantly, there'll be a slow growth of herd immunity. And at some point around the peak, those who are vulnerable, which include the immunosuppressed and the elderly, will be asked to self-isolate for a period of up to 12 weeks. And the idea is by the time they emerge, and this isn't total lockdown in that case, I think it's halving social contacts. It's not the same self-isolation as if you're infectious, but they'll be asked to halve their contacts, increase distance with people, rather than be locked in for 3 months. By the time they emerge, the hope is there'll be sufficient herd immunity in the rest of us that they'll be at less risk. So this is very much outside my field. I sent this as a redacted copy to show you, and because it came up earlier, I sort of asked permission to show it and have done it, but it doesn't necessarily tie into things. I know the argument from and behind the survey, and this has come up elsewhere, is we are the intensivists, or the people involved in this, between us, anaesthetists and intensivists, we are the ones who are going to get hit by the surge. We can see our ITUs are already full. We should be the one saying, Boris, you've got it wrong. And I can see the logic in that, but actually this is when they make reference to we've made this based on an analysis, this is essentially the analysis. So I thought it'd be useful just to feed that back. Just going back to, so I have finished, just to reassure Pete. Just catch up with where I am. I think I've finished. I think that's it actually. Yeah, so going back to this sense of urgency, I think I'm reasonably confident that by the end of the week, everyone's going to be on a 10. So I will stop there. Thank you.
That's really good, and thanks for that, Ganesh. I'm going to just again loads and loads of questions. I'm going to summarise a few of them and just make a comment, because one of the things just listening to the whole of this, and yeah, I'm an intensivist. I do very little anaesthesia, but my own view at the moment is that anaesthesia is really the cavalry that are coming in to save us, and we're quite fortunate in the UK that we have that ability to cross-skill in the way that we do. There's been a lot of questions on working outside of people's norms and the liabilities at times of surge and so forth. Concerning the wash up after this, there'll be errors, misjudgments, and historically there have been miscarriages of justice. And the question is, and I suppose you can only answer it for the ICS, and I'll ask Kathleen the same question when she wraps up. Will the four bodies have our back?
Right, sorry, I'd muted myself, which is an unhelpful thing to do for that particular statement as well. So I would say a very strong yes, and that is exactly what we were trying to reassure people. I had shown, I don't know if my screen's still up, but I was showing the GMC statement, but certainly as far as the bodies, one reason for having a joint site is so that people don't have any kind of inconsistencies that leaves them just sort of scratching their heads trying to figure out which bit to read, but also just to make the point that any support, any framework we give is very much sort of unanimous. And as Peter knows, anything that's posted on that joint website goes past all four leads, so RCOA president, the dean of the faculty, Peter and myself. So it's endorsed. It's not just somebody sticking some stuff up that we're going to then deny later. And that's just the website, but I think the ethos behind it is very much the same. All four of us are fully behind people working as they need to do as we go into this. As is government and as are the regulatory bodies.
That's great. Thanks very much, Ganesh. So I'm going to do a couple of closing remarks, which is really to say people are asking about can non-members get it? It's absolutely free. It will be on the website, I believe, by Monday. As I said before, I urge you to get your senior management to look at particularly the experience in Italy, where I think that will be quite sobering to make sure that people understand what is going on and what is about to face us. Please, will you link to it when it comes on? Tweet, use whatever social media you've got to try and make sure that there's a widespread viewing of this webinar. And I'm going to finish by getting our president, Kathleen. The question that was left for her was, will the Association of Anaesthetists have our backs when there's the wash up of all of this, and if there are accusations flying? Kathleen.
Sorry, I was trying to unmute myself. There's one word. Absolutely. I'm going to expand on the one word and say the Association of Anaesthetists, the Royal College of Anaesthetists, the Faculty of Intensive Care Medicine and the Intensive Care Society have your backs. Is it right now, Peter, for me just to bring this to a close so that everyone can get on with Saturday?
You're the final thing. I'm saying nothing more.
Okay, right. There have been 909 people online. It's absolutely amazing. This is going to go on the website and hopefully it's going to go viral. And hopefully we're going to get everyone that needs to hear these things online to realise the benefit of what we've put together today. I'm going to say thank you to Tim for the information and for the guidance that we know is going to come out on the joint website. To Dr. Song for his important clinical insight and detail on the secondary complications that we haven't really heard much about. To Dr. Enrique Storti for the reality of major civil events. Somber was the word people used. To Matt Davis for planning, preparing, practicing, performing, a sensible to-do messages and also what not to do. Going by webcams. Rob Self, let's include Shapiro, the pyramid, in all our planning and preparing. It's what's going to have us with a healthy workforce in November, December 2020 and moving forward. To Kathleen Ferguson for the rallying call on leadership and for ensuring that we have a facility for collective decision making. We have to have each other's backs here. And to Ganesh, lastly, for a fantastic presentation on where we are at right now. You need to talk early, we need to wait for that important, difficult decision-making material to come out very soon. It's been a fantastic morning. Commend it to your colleagues, commend it to your managers. And the last word, I wish you well. I hope you stay safe. Keep your families safe, keep your colleagues safe, and work hard for your patients. Thank you.